Good afternoon, everybody. Thanks for joining us. Give it a couple of minutes for some more folks to join us, and then we'll get started. There we go. It helps if my mic is on. I think we're going to go ahead and get started. I'm just excited to see so many people hopping on to join us today. So just want to welcome all of you again to From Vision to Vitality, how to launch a clinic like Maddie's Place. I am Katie Tully. I'm our Director of Advancement and Marketing here at Maddie's Place. And I, again, am excited to welcome all of you back for the third webinar in our series. If you missed either of the first two, please don't worry. You can find links to both of those, along with any slide decks or additional material that we've shared on our website at maddiesplace.org. You just got to go to the top and click the resources tab and select Want a Maddie's Place in your community. And you'll find all of those resources there. So just like we've said over the last couple of weeks that we've been meeting together, over the next couple of months, we're going to continue to walk you through everything that we've learned about launching the first pediatric transitional care facility of its kind in Washington State. And our goal really is to help other communities build similar clinics so that we can serve even more babies with neonatal abstinence syndrome and prenatal substance exposure, and do our best to support their families that are also impacted by substance use. So we're really glad that you all have joined us today. Before we start, we've got a couple of quick housekeeping items we want to share before we jump into things. Today's session will run we'll do a presentation for about 60 minutes, and then we've got at least 15 to 30 minutes here for a Q&A at the end. I always find it really interesting and exciting to see where people are joining us from. So if you want to just go ahead and practice utilizing the chat and the Q&A features, the chat is where you'll be able to chat back and forth with one another and offer up comments and that kind of thing. I would love if you would drop a note in there about where you're joining us from. And then the Q&A feature is separate from that, and that's where you can submit any of your questions that you might have for me or for Sean today. And we will be, that's where we'll be pulling all of our questions from. So. There we go. Too many screens at one time. So today's Q&A will be moderated by Carly, our communications coordinator. Just a reminder, this session is being recorded. So everyone who registered should be receiving a link to that recording after we're done meeting today. And then again, we'll also post any slide deck or additional materials on our website. And now I'm excited to introduce you once again to our speaker. Sean Cross is a fourth-generation Eastern Washington native with deep roots in the region and a rich family history of more than 130 years in law. A proven leader in both the legal and nonprofit sector, Sean has spent more than 46 years helping to shape the Spokane region through his career as a corporate lawyer and his service on numerous boards. In 2018, Sean's leadership took on a new dimension when he incorporated Maddie's Place. And Sean has served as our founding chairman of Maddie's Place on our board from 2018 to 2022, when he finally stepped down to become our organization's first president and CEO. position that he still holds today. Sean currently sits on the board of directors and the executive committee of Excelsior Wellness, which is an innovative alternative healthcare system that provides youth-centered, community-based, and culturally sensitive care to thousands of families in our Eastern Washington region each year. So we're glad to have him leading today's discussion once again. Welcome, Sean. We're going to turn it over to you.
Thanks, Katie. It's great to have you all here again. Time flies when you're having fun. I think it was August 27th when we last met, and so it's almost been a month. I'm just thrilled so many people are interested in learning more about our story and how it might apply to benefit with what they want to do with their dreams and their individual communities, and that this is becoming quite a movement. So we're just really humbled and excited to be a part of it. I have to go through these kind of normal, boring sort of disclaimer type things. As a lawyer, I am a lawyer. That's sort of a confession. I'm not bragging or anything like that. And because I know how much people love lawyers. But the point is that I have really zero expertise or background in behavioral health and mental health and substance use disorder and maternal infant health issues or healthcare generally. So it's sort of ironic for me to kind of be talking about these subjects with people online right now that I'm sure in most cases know far more about the subject matter than I probably do. I also, it just kind of goes without saying that I'm not giving legal advice. We do want to be a resource and give templates and legal related documents and articles and bylaws and policies and procedures, whatever we can give to you. But if you need legal advice, you're probably going to retain a good friend or something as a lawyer to give you some counsel for your state and your circumstances. So, but we are again happy to share anything that we've got. So, and just looking at the goals that we've got, they're the same goals that we've had. If we can go to the next slide, Katie. We are. I'll wait till you can click that on. It's been pretty much the same reason why we started this series was really, I feel like over the 8 years that I've kind of been doing this, at least in my own region, I kind of felt like John the Baptist out in the desert because nobody really even knew about this problem. Everybody seemed to know that there was a drug crisis in America. I think we're pretty well aware of that. But the impact that it's had on infants and what's happening with moms, I think there wasn't a lot of awareness about it. So first and foremost, I think with our social media platforms and followers and with this series and everything, I've simply been trying to increase awareness to talk to as many people, political folks, funding folks, whatever, as I can to go, you guys, this is what's happening in our country and in our community here in Spokane. And then also, I think the real big part of this is we just want to encourage you that do have an interest in starting a pediatric transitional care facility or PTCF in your community. We just want to encourage you to do that. It's not easy. We've been at this for 8 years. We haven't reached the finish line at all on permanent sustainability or anything, and so it's a long haul fight. But we need to encourage each other, I think, with anything where it's a challenge. And then also, we just want to serve as a resource. We don't have all the answers. We don't even have all the questions, but I think we have over the last 8 years stumbled on some things that we're happy to share, whether it be mission and kind of thinking more about that as it relates not only to the infant but to the parents. We're looking at a dyadic model with really trying to heal and be part of the healing process for both the infant and for the parents and the caregivers. We can talk about strategy, fundraising. I'd never dreamed that we'd raise $16 million. We just got $500,000 in grants just this last week. So just since we had our last meeting, we've gotten more that's come in. And then happy, just as a corporate lawyer, this is sort of my natural kind of comfort zone, is talking about boards and governance and who does what and org charts and all that kind of boring stuff. So we want to share whatever we can there. And then, I'm a failed congressional run. I had one congressional run. I was one and done. So I must have this built up kind of political desire, but this has been sort of fun because there's so much public policy around it at both the federal and the state level. And we've got lots going on in DC potentially, and I think you all could be part of us working together on that. And then also just connections. One of the things that we really learned is, there are people all over the country that want to do this, we've identified, 150 individuals sent us their information and gave us their consent on the form to share that information with others within what we're calling cohorts. And we've identified 30 cohorts around the country that are clusters of individuals. And so since our last meeting on August 27th, Katie sent out a form. She had an introductory email to each one of the cohorts just saying, hey, you're not alone. These are the other individuals that are in your state, whether it be Florida or Texas or Michigan or Virginia or California or Oregon or whatever. And we'd like to introduce you to each other. And then we sent out a form about a week or two after that, a couple of weeks ago, just kind of a template for folks to follow. And we've got kind of clusters in two other countries too. So we sent that out for you to kind of be a template for your form. Like, did you meet? Who was at the meeting? Did you decide on a facilitator or a chairperson? Did you have a chance to talk about where you might want to put the facility? And do you have any state political connections? Or so anyway, and several of those groups have had meetings since we sent out that form. So one thing that I do want to just highlight before we start going on to the next slide on building the case for your community is don't forget to follow up with us by filling out that cohort assessment form that we did share with you, because this will really help us coordinate our efforts with you and enable us to support you in the best way possible. For example, I'm going to be back in DC in November, and probably after that, working on the Miracle Act, which is intended to have Congress direct Health and Human Services to have a 3-year study on the prevalence of substance exposure and NAS nationally. And the more I know, my lobbyists, federal lobbyists, are very excited that we have people around the country that are very excited about that, because Congress is not going to care too much about one clinic in Washington State, but they're going to have a lot more interest if there's 30 different groups around the country with their political connections. So anyway, if you could fill out those forms, have a meeting. That's the next step, is to have your initial meeting and then give us some feedback on that. Okay, now to get into kind of the purpose for this third webinar is really building the case for your community. When we first started dreaming about Maddie's Place, one of the biggest questions that people asked is, well, what is the problem? What's the exact nature of the problem? What's the scope of the problem? Is what you're proposing as a solution, is it really needed? And one of the things that made this so challenging from my perspective is the lack of data, or the availability of data, or the age of the data that's available. The other thing that I think has been confusing, at least to me, and I think to others, is we really have different categories that we're talking about. Are we talking about substance exposure, infants that have been exposed to any substance? Are we talking just about neonatal abstinence syndrome, which is a subset of those that have been exposed that exhibit specific symptoms of withdrawal right after birth as they go through withdrawal? Or are we talking about neonatal opioid withdrawal syndrome, which is a subset of NAS? And I think when I throw out these statistics of a third or whatever, we think a third of live births or whatever, I'm really talking about substance exposure. And we'll get into that a little bit more. So we're talking about both. We're talking about substance exposure and NAS. And so we need to get data. You need to get local data, state data, county data, and need to understanding what is happening in your community. And you need to have those answers not only for yourself, but for those that are going to contribute money, and policymakers and hospitals and partners, and also for your model of care. So in our situation, we had an independent study that came back to the legislature and said that, wow, Washington State is a hot spot. We're 180% of the national average, and not only that, but in Spokane County we're 340% times the 2021 national average. Now, there's a couple more things that are really important in this. One is we don't have any national data after 2021. How does that happen? When you think of COVID, we knew how many people were in the hospital week by week, how many people died, how many people were sick. And here we have no national data in our database for how many infants, tens and tens and tens and tens, potentially hundreds and hundreds of thousands of babies that have been born substance exposed. We simply don't know. And in Washington State, you'll see that we have data for 2022. That means we don't have data for 2023, 2024, and we're almost to the end of 2025. And so one of the things that I've been jumping up and down about with public policymakers is this is not acceptable. We're in the middle of a historic drug crisis in the United States, and we're getting new drugs. The situation is worsening. We don't know what the impact, for example, is of fentanyl on behavioral development during early life for a child, and we're just so far behind the curve. So let's go to the next slide. So I wanted to give a shout out to folks in Alabama, Christina Adkins and Maggie Lawrence, Craig Lawrence, and Debbie Hancock. They have been inspired, in part, I think, from what we're doing to start Bridged Beginnings in Birmingham, Alabama. So we loved getting that email from you all, from Christina, and really appreciated all the steps that they've taken. One of the things that I thought was really interesting about the attachment or kind of the flyer that they've prepared, and this is really, really great. I thought, wow, I'm just going to show this as a how-to. It's understanding the challenge, why it matters, our solution, our goal, and next steps. I mean, this is really very, very well done. And so why it matters, when I looked at that and I saw, wow, Alabama is at 32 infants that are Medicaid births diagnosed with NAS in Alabama in 2021. I mean, that is a very, very high number. That's a very, very high number. And so I think this is really pointing out to people kind of the extent of the problem. So I just thought that was really, really good. But understanding what's happening in your locality drives everything else. It drives funding and partnerships and credibility. No one's going to invest in a solution unless they're convinced the problem is real and urgent in their community. But I will say one thing, the backdrop to all that you want to do when you talk about specific local numbers is I think there's a huge awareness in the country that we are in the middle of a historic drug crisis. People read about the overdose deaths. They're reading about what's happening, and I think people are very, very concerned about it. So you're talking into a space right now historically that I think resonates with people. You just need to have a little bit more local data. So let's go to the next one. So how do you find that data? And fortunately, we've got this thing called Google. But you're going to look at the CDC, even though the statistics may only be up to 2021 to the substance abuse and mental health. That agency, SAMHSA, state sources, are really good with this data. Your Department of Health, in Washington State is called Department of Children, Youth, and Families. It may be called Department of Youth and Families or something different in your state. In our state, it's called the Healthcare Authority. That authority oversees a $32 billion Medicaid pool for the 2.2 million people in Washington State, over a quarter of our population, that are supported by Medicaid. And then managed care organizations can be great sources of information. Of course, you have local sources. Because we are experiencing a huge increase in overdose deaths in Spokane County, this has become a very hot political topic. And our Spokane County Health District has a dashboard that publishes information, pretty current information on overdose deaths and related data. The other thing that I've been using to kind of fill in some of the gaps is, let's say, for example, we only had NAS data in Spokane County for 2022. My argument to the state and to public policy folks has been, well, let's look at the related data over the last 3 years, and then you can pretty much extrapolate what's happened with NAS births. For example, overdose deaths in Spokane County over the last 3 years have doubled. Emergency management system responses have doubled. Drug seizures, just by amount, have doubled. And so it's logical to assume that births have also increased greatly, and so that we're probably not at 340% where we were in 2022. We're probably 600 or 700% the national average. That starts to really get county commissioners and others, city council members and people, looking at their shoes pretty quickly, that this is an urgent situation. So, in Spokane, we have been, we believe that about a third, up to about a third, and maybe even more of all live births are substance exposed. Now there'll be a subset of that exhibit symptoms. And then you get a question into, well, what symptoms? What if you have certain drugs that don't manifest symptoms before they're discharged from the hospitals? What if you miss code? What if you have, we don't, I think during one of the last webinars, someone in Pennsylvania said that they had mandatory UAs. I don't know how many states do, but that's something to be knowledgeable about in your particular state. We have a recommendation from our Department of Health for UAs by our hospitals, but it's not mandatory, and so we're not tracking that. And so without mandatory UAs, I don't know how you really get a handle on what is going on, but I know that's a public policy thing, and there's people on both sides of that. So anyway, that's kind of some data that we've seen. Some additional data, and I think this is I would surmise that that a lot of this applies to your area too. Our study determined that substance use trends in Spokane have changed pretty significantly over the past 2-3 years. And the main reason is polysubstance, because their average infant was exposed to 4 substances in utero, and 75% of our patients were exposed to fentanyl. The combination of those two things, polysubstance and fentanyl, is really changing the dynamic in the NICU units in our region, and I would think beyond our region. This is of the first 71 infants, we've treated 153 infants as of today at Maddie's Place. We're coming up on our 3rd anniversary next week, October 3rd. But the study that Washington State University was commissioned to do by our state legislature broke down, what substances our infants were exposed to. So again, this is not just NAS. This is any substance. So you'll see that meth was in first place, fentanyl second, but then you've got tobacco, methadone, marijuana. Now we've got in our state, Oregon, many other states, marijuana has been legalized. And yet, what percent, and we see that a lot of younger people that are under 30 are drinking less alcohol, but they're smoking more marijuana. How many moms or those that are pregnant feel that they're safe to smoke marijuana while they're carrying an infant? And then we've got morphine, alcohol, heroin, and then other drugs that you'll see there. So the other thing that we've been really focusing on, and this really all started for me with an article. It's on our website under the resource tab, and then under the sub tab, additional reading. And basically, it's a peer-reviewed article that was done on Lily's Place, which is the first PTCF that was formed in the country about 11 or 12 years ago in Huntington, West Virginia. And that study showed, based on 2016 data, that the cost for a month's stay at Lily's Place was roughly 17% what it was at the NICU unit in Huntington, West Virginia, with arguably better outcomes. And that has been sort of a consistent theme that we know right now that and we'll get into kind of per cost data in just a second. But the average stay in the NICU unit in Spokane, Medicaid in our state is paying almost $70,000 for that same 30-day stay. With our infrastructure and our costs and the way our staffing model is designed, because we don't have a lot of fancy medical equipment and things like that, our cost is about a third. And that's one of the arguments that I think is going to be important is as Medicaid is being cut back federally and we're seeing sort of where this is headed, it's going to be important for the states to really maximize efficiencies. And so I think we're in a sweet spot where we can really argue for that. On a per diem basis, what our local hospitals are being paid by Medicaid. So this is not the full amount that would be paid for regular insurance, but just for Medicaid itself. In 2024, it was almost $2,600. I'm not sure exactly why it dropped in 2025, but it's running at $2,100. This is data that we've gotten from one of our MCOs, one of our managed care organizations here in the state of Washington that's been partnering with us. Well, we can provide this, I think, better level of care because we have a non-pharmacological method rather than giving the baby morphine in the NICU unit for roughly $800, so almost a third the cost. And the thing that's really profound about this statistic is this is just the care for the infant. In our model, we're treating and taking care of not only the infant, but the biological parent, usually the mom, if we can get the mom to come in and stay with her baby. So this doesn't take into consideration the savings of the infant bonding with her biological mom, staying with her mom, staying in custody with her mom, and not going into the foster care system, which in our state costs over $200,000 over an 18-year period for a NAS infant. And it's not working because about 40% of NAS infants, boys that go into the foster care system in the state of Washington, will be homeless by the time they're 18. So it's not a system, at least in our state. I mean, I was working for a lot of children, and it's a wonderful system. It can be wonderful, but there's a lot of things that aren't good about, that would be better if we could keep the dyad together. So I think we've covered some of these statistics before, but we're up to 153 babies. About 41% are voluntary with the mom coming in with her baby. The others are dependency, where the state is basically the child is going to go into foster care. It's interesting when you're looking at grant writing and other things, and people are really concerned now in healthcare with not only efficiencies, but with innovation and also with with access to care. So you'll see that 19 of our 153 infants are American Indian or Alaska Native. So that's 12.5%. Well, and our population in Spokane is overwhelmingly Caucasian. The numbers that we're seeing for Native American is about 6 times what it is in the population. So from an access to care standpoint, we're really reaching that community. We're excited that we have opportunities with our local tribes to possibly do a joint venture where we do a clinic together on reservation land. So that opens up opportunities, funding opportunities, and different opportunities. For Black and American, for African American, the numbers are about twice. Same thing with Hispanic and Latino. So we're seeing that we're reaching some communities that I think are really struggling with drug use. The big, I think some of the statistics here that are interesting is that the majority of our moms and parents, when they came to us, were housed. Almost all of them now are housed. And so we've had the opportunity to find housing for them. 95%, nearly all of the babies who stayed at Maddie's place with a parent remain in that parent's care. Now, that's a startling statistic. That's one that you guys can use around the country, and that, we're going to keep drilling down on this and finding out how far out do we go. Is that recovery in 6 months? Is that recovery to a year? We're going to have to add additional staff people to keep track of what's happening. And we want to do this not only for the sake of just accumulating data, but it gives us another touch point with those with our alumni to really try to help them with anything that they might need in the way of food or housing or anything else. I think I mentioned that if you've got gaps in trying to determine your NAS statistics or substance exposed statistics in your county, one of the things that I've gone back to is looking at, okay, the fire department, what are their EMS responses? And you'll see in Spokane County, they doubled between 2022 and 2024. Overdose in Spokane County have increased by 162% from 2020 to 2024. And there was a huge increase, probably another 40% increase that we're seeing this year. So you can see the other statistic that is really well, so this is overdose deaths in Spokane per 100,000. You'll see that we're about 3.5 times the rate in the United States. We'll see that we're twice Seattle, more than twice Tacoma. We're above, not by a lot, but Portland, Multnomah County, and we're above San Francisco. And then you'll see the related percentage increase over the last 2 years. We hear frequently that things are getting better around the country. I have trouble really believing that, but I know that there are some that say the fentanyl wave started on the East Coast and worked its way over to the West Coast. So there may be some of that going on. We may be kind of the tail on the fentanyl wave that's come across the country. But anyway, let's go to the next slide. Okay, so you're going to get more data, you're going to find more data, and you're going to look at whether it's the CDC and national data or state sources, departments of health, local sources, hospitals, county health districts, community dashboards. And then even if that data isn't available, you've got other indicators for overdose rates and EMS calls, drug seizure, foster care placements, other things that you can look at. You can think of it like a mosaic. No single data point is perfect, but together they give you a clearer picture of what's happening in your community. Now, once you have the data or you start to put together the data, the key is to translate it into a story that people can understand and care about. For example, you don't want to just say, there were 3,000 NAS births in our state last year. You can say maybe that means that nearly 10 babies every single day in our state start life in withdrawal, and how many are born every hour or whatever it might be. And right now, most of them are treated in crowded NICU units, often without their parents. One of the things that part of this is it's a hard story to tell, but I think unless people really see how bad this is, I think there's a direct connection between people understanding the severity of the problem and the seriousness of the problem and responding to it. It's a hard thing to watch, but one of the resources that is available on our website, and you may have these yourself, but under the tab Further Reading, we have videos of infants going through withdrawal. We have those videos. You can listen to their screams. You can see what's happening to them, and they're very hard to watch. But I think part of telling the story is people having an emotional connection with this. I don't know if I can pull it up really, really, really quickly, but I wanted to point out a picture that happened just this last week, and hopefully you all can see this. But the mayor of Spokane came to Maddie's place last week, and this is her in one of our nurseries. She broke down. She also just this summer gave us $300,000 out of our city's opioid abatement fund. But I think I've seen that so many times. And I just think, once you make that emotional connection with people, which I guess is really them becoming, is having a sense of empathy for what this population is going through and what they're struggling with, that's where you really get people's attention. whether it's public policy or whether it's fundraising. I had a just a quick anecdote. If I got Katie, do I have time to tell a quick anecdote? I had a guy that I'd never met before that came along with a friend to see Maddie's place, and I was 5 minutes into my spiel, and he said, "Well, you know what we should just do with all these women? They should just be sterilized." And I kind of dropped my jaw and okay, and then went on with what I was talking about. The three of us, two visitors, and with this, including this one guy that had made this horrible remark, went back into the nursery, and I had him talk to one of our moms, and it was all not scripted at all. And she said some incredible things. I could see tears forming in the guy's eye that had just said this. And later on that afternoon, one guy came back with a check, this is literally true story, for $170,000. And the other guy who had made that harsh comment gave me a check for $50,000. So making that emotional connection really can get people beyond their biases and the stigma and everything. But so anyway, just tell that story. Um, and then ties in with anticipating misconceptions. Um, I think a lot of medical professionals, the standard of care right now is that NASP babies are adequately treated in the NICU unit. But I think you can point out that NICU units are designed for intensive medical care, not week-long comfort care, and that a pediatric transitional care facility can provide specialized, cost-effective, family-centered support without morphine, and can also promote bonding, which is, I think, one of the great things our dyadic model does. So let me see here. I think we can go to the next one. So as you gather your data and to tell your story, it's time to bring in partners. And I think you start with community leaders, champions within the system, county, city contacts, folks working in the behavioral health and SUD space, the press, foster parents, managed care organizations. It may seem logical to contact hospitals, NIC units, and OB practices first, as they're on the front lines and often see the need most clearly, but you may run into some real barriers. So I would say don't wait to talk with Medicaid and managed care organizations. One of the biggest breakthroughs that we had was an organization called Excelsior Wellness, and I'm on vice chair of their board and involved with them too. They began actually almost 100 years ago as another organization, the Sisters of Providence here in Spokane, that were taking orphans off of the trains that were coming from the East Coast. And by the time they got to Spokane and Seattle, a lot of these orphans were disabled. And so they had an orphanage here, which by the time of 1980, Excelsior Wellness took over, and they've expanded the care to provide medical care and treatment and behavioral health, primary care, and then also they've extended it out to the family. Anyway, we came in touch with them, and their CEO, a guy named Andrew Hill, said, "Well, this is so exciting what you're doing, because we're spending all this money downstream, for social services and behavioral health and for housing and for everything, which we need to do, but we're not doing anything on the continuum of care during the first 3 months of these infants' lives." And that's kind of the niche that you're filling right now. And so he said, "We want to partner with you." And so he asked me, "What's your biggest donation?" And at the time, I think it was early on in our raising funds the first 6 months really, and it was, I think, 125,000. He said, "Well, I'm going to give you 200,000. And then I want to contract with you guys and provide you all these services." And included in those services was an introduction to our managed care organizations in Spokane County, of which we have 4. On this part of I guess it's on the right side of the screen, you'll see a picture of some folks from Coordinated Care. Coordinated Care of Washington covers 100% of the foster care expense in the state of Washington. They're a small Medicaid provider right now. They only cover, I think, less than 5% of our market, but they're this incredible organization. And they quickly grasped on to what we were about. In fact, one of the leaders had mentioned that this was very personal. because of a family situation that she had that involved addiction. And so um, we ended up getting $1.1 million from coordinated care. And, I can't imagine their margins are that big. They're a Medicaid, provider or payer in our state. And so I'm sure their margins are low. But their CEO believed that this was a significant enough investment that it was really going to change it was going to be a national model it was going to have a big impact on the foster care system. And so they invested that kind of money with us. So you might,
Sean,
uh,
can I interrupt? We've
yeah,
got, I do want to address just a question that just came in the chat. Are these donations or investments? You've used the word investment. How have we classified those?
yeah, no, they're donations. It's a really interesting question. The way that half of it, well, 96,000 of the 1.1 million was a grant that we got, a community grant that we won in a statewide competition. About 500,000 of that 1.1 million was payments that they made to us under a contract that we had with them to pay us $1,050 per day per infant. And that was based on that contract that we opened this facility 3 years ago. Our healthcare authority, 5 months after we opened the facility, directed coordinated care to discontinue the payments to us because this was not covered under our state Medicaid program. So a couple things could have happened at that situation. They could have asked that the 600 or 500,000 be disgorged to be returned to coordinated care. They did not do that. And then secondly, that could have been the end of our operation. But I looked at what I thought I was able to raise. I looked at what we had in the bank at that time, and I went back to coordinated care and said, if you can get me $500,000, that I think will get me to September. And we are negotiating with the legislature for a state pilot project that I was hoping would be approved in April, and we would start to get funded in August or September. And that's exactly what happened. And so we ended up, it was a donation. I don't know how they showed it on their books, but because of what they did, we took out a full page or a half page ad in our local Spokesman Review to thank Coordinated Care for what they did. And it's a committed partner of Maddie's Place for providing over $1 million in funding. So I think it was an investment. I mean, it was just a donation. There are no strings attached. It was just for our operations. We wouldn't have been able to open without them, and we wouldn't have stayed open without what they did. So there are organizations in the foster care system and the payer system and the insurance system and the Medicaid system that see that this could be very significant and are willing to get on board. So that's the main point. Thanks for that question. Great question. So anyway, I think it's really important, and I'm sure all of you, already have all these connections. But in Spokane, when you look at community connections, these are all the different organizations that we work with. We want to be collaborative. We want to get an A+ for collaboration. We're not trying to reinvent the wheel. There, in all of our communities, there are incredible nonprofits and for-profits and organizations that are doing in counties and cities that are doing amazing work in this space. And we just, want to collaborate with all of them. And we found that everyone that we know is excited to work with us and to collaborate with us. Everyone loves babies. I think it all comes back down to that. So build relationships. And a lot of you, as we're looking at these cohorts, I've gone through that list of 150 that registered for the second webinar and gave us all that information. You are a talented group. I mean, there are physicians out there. There are, I don't know how many NIC unit RNs that are out there. There are specialists in behavioral health and, mental health and substance use disorder and everything. It's really exciting. And it's also exciting to see, in these clusters, what you all have that you can bring together. I mean, when we started this, we had a nurse and a lawyer. So, not a very impressive group, but it's been blessed tremendously, far beyond anything that we could have organized or planned. So I know that you all, building community connections is really important. Don't forget child welfare and early learning agencies. They see the ripple effects of prenatal substance exposure every day. Um, and so, I wanted to encourage you to form an advisory committee or a steering committee, and try to get champions from each of these sections. And if you don't have a facility yet, having respected leaders at the table will build that credibility. I will say I will say that once some people go, is there a chicken and egg on whether you get a facility first or you raise the money first? I think that we bought our facility with $16,000, $10,000 down, and we had $1,000 a month to cover utilities. They gave us 6 months to raise the money, which was only $1.25 million. And COVID hit, so they extended it for 6 months. I think it's when you have a facility that you've identified, I think it makes it easier to raise money. So that's just the thought. And for us, all that we would have lost was our $16,000. So just an idea there. So credibility before funding or a facility. You want to leverage your team's expertise and your lived experiences. You want to use data to show the need and that it's compelling. You have visuals to show this is what's happening, whether you know it or not. When all these hundreds of infants that are born in our city go through withdrawal, this is what the NICU units are seeing. This is what people are seeing. And you want to start with informal coalitions and advisory groups, identify champions in healthcare, government, community networks. And I know a lot of you may be thinking, well, we don't have the funding yet. We don't have a building. We don't have results to show. That's okay, because we were in that exact same spot too. So what you do have is expertise, passion, and data. And we've got a national problem that people are really worried about. So you use that. The rest will kind of fall in place. At least that's been our experience. So whether it's clinical experience, professional, or personal, build these advisory groups, even if it's informal. Figure out what the best way is to meet virtually or whatever. Partner with organizations that already have credibility. And the truth is that credibility doesn't come only from the outcomes. It also comes from preparation, from collaboration, and from persistence. So I want to really encourage you all to meet with your cohorts and to share information. Katie, I don't know what thought we've given or what you want to say about those that are in the dots where we don't have cohorts yet. And so we want to help those people too. We're not just going to help just the folks where there's clusters of people. But I don't know what thoughts you have on that.
Sure. And we have had a couple of folks that I've got, I think, maybe 4, maybe 5 folks that are, as far as we know, the only person that's identified, hey, I'm in this state. And then others that are, pretty close to a border of a neighboring state that's got some, we've identified a cohort there. So if you're in a region where maybe you're the only person that we've been able to identify in your state, we've tried to connect you with a local somebody else in your region. But like I said, we've got a handful, maybe 4 or 5 that we don't quite have anybody to connect you with just yet. But if you're interested, if you haven't been receiving our emails and been connected with a cohort yet, let me know. Go ahead and just email us. It's info@maddiesplace.org. And let's connect and talk about maybe a neighboring state, maybe somebody in a larger region we can connect you with. We've also had some folks that I tried to reach out that maybe didn't identify, all the questions that we ask when you register for this webinar. We try not to make them redundant, but it really does help us. So if you filled it out once, that's great. We don't need you to fill it out again, but we did have a handful of folks, another handful of folks that didn't identify which area of the country that they're in. And so we weren't able to connect you. So if you haven't heard from us yet, please reach out, let us know. let's have the conversation and see who we can pair you up with and be part of those conversations. And we've got another, we had over 100 people register for today's webinar. It doesn't look like everybody has joined us live, but we'll get the recording. And so, I'm scanning through those registrations every time that we have a webinar. And so I anticipate after this that we'll be adding some folks to cohorts. And so I'm working on building those lists and just making sure that you all are staying connected. But if for some reason you haven't heard from us, please reach out again. Let us know. We'll get you connected.
The other thing, one thing too, just to reiterate, if you have met, if you could fill out that form and send it to that info@mattiesplace.org, that would be really, really cool. And then if you haven't met, if you could meet, sometime in the near future, and then fill out that form, that would be helpful to us. And I think included in the form, if I recall, is, what do you need? How can we help you? We are starting to have conversations about subsidiaries of Mattie's Place and people that would be very interested in being part of Mattie's Place and kind of being under that umbrella. And so we are actively working on that and looking at clinics in Bellingham and also possibly in the Portland metro area, kind of focusing initially on Vancouver. We also, I formed a single member LLC called Mattie's Place Florida. I've been working with Dr. Juliana Hellman in Melbourne for some time. And so, many of you, I looked at building bridges or bridges building. What was that? Our Alabama friends, and they're heading off. And if you want to be independent, that is absolutely astounding and wonderful. And we'll be part of the sisterhood of clinics around the country. We only have 5 now. We want to have a whole bunch more. Whether they're Mattie's Place clinics or not doesn't really matter. What really matters is starting these clinics around the country and starting to impact these babies and these moms. But I just want to let you know that just this past week, my board of directors really kind of gave me the green light to run with this and really help get as many clinics going as possible and start fundraising and everything. So anyway, but we need that form to be filled out.
Can you talk a little bit, this might be a good time for you to talk a little bit about sort of the federal work that you're doing and how that could impact or how folks that are joining us could be part of that?
Yeah, thank you. So I kind of know enough about politics to be dangerous, and so I recognize, I did okay until last year, and I realized we were running into a budget crisis in the state of Washington this last year, and then with the federal cutbacks in Medicaid, you could see it was a perfect storm. And so I fortunately hired a really good consulting firm, a lobbying firm that happens to be based here in Spokane, and they have a state lobbyist and a federal lobbyist. So last year, without the benefit of this lobbyist, because I had run for Congress a while ago, and the woman who beat me quite badly, by the way, became a very, very close friend, and she became chair of the Energy and Commerce Committee in the U.S. House. And so she introduced a bill that I had been working on for about 3 years called the Miracle Act, and it stands for Mattie's Infant Recovery and Children's Legislative Emergency Act. So I came up with that in the shower. That was pretty bad. But anyway, the Miracle Act was introduced into Congress as a bill on July 7th of last year. Of course, it was an election year and blah, blah, blah. It didn't get anywhere. So we're working on reintroducing that bill again. And I was back in DC in July, and I'm going to go back there again in early November. And we've identified potential co-sponsors on both the Democrat and Republican side in both the House and in the Senate. And one of the things that my lobbyist, John Colton, is very excited about is the fact that we've got this interest that has popped up around the country. Because quite frankly, if it's just one clinic in Spokane, Washington, nobody's going to care. But If it's 5 clinics, and then you've got Generation O that has 7,500 families that have been adopted that are NAS infants that are on its Facebook group, and then if you've got these webinars and you've got 150 people in throughout the United States that want to start Maddie's Places or similar clinics, that's going to start to get more people's attention. And so one of the things that is a possibility, is as this thing progresses, we've got a few more webinars to do. We're getting more information from you. If this level of excitement kind of continues, then there probably will be opportunities for us to meet in DC. And as many of you as want to come, to participate, to show that there's a groundswell for this around the country. And again, what the Miracle Act would do, because I've become convinced after 8 years of doing this, that if you don't have the data and it's not good data, then it's a problem. You don't know the scope of the problem and how bad it is. And so as we've gotten more data, we had people here at the state level that basically said, go practice law to me. NASA is not a problem in the state of Washington. And now I've got the same report from that same healthcare authority saying, well, guess what? It's a real problem in Spokane. We're 340% the national average, and you represent Spokane, right? And it's twice the national average in the state of Washington. So I'm convinced that we all know that there's power in data. So what this Miracle Act would do is it would direct Health and Human Services to do a 3-year national study, state by state, tribe by tribe, on the prevalence of substance exposure and NAS in the United States, and also do a study on the outcomes at the 5 pediatric transitional care facilities in the United States. I believe that's going to be introduced into Congress again. I think that the administration, even the current administration, is sympathetic to that. The First Lady actually went to Lily's place twice during the president's first term. So who knows? I think, and the federal match is already there for Medicaid coverage. We just need the states to amend their state Medicaid plans to match that federal component. And there's not, even with the cutbacks in Medicaid, it was a permanent change in Title 18 USC to permanently amend Medicaid to provide for reimbursement of the federal component of NAS services at state licensed pediatric transitional care facilities. So we're okay, I think, on the federal thing. We just need the study and the federal money to do the study. I mean, our study in the state of Washington in Spokane was 190,000. This is going to be a much bigger study nationally. And then I think once we all, in the next few years, get all that data, then that's going to come alongside wherever you guys are to really get your states fired up on amending their state Medicaid plans. So long speech, sorry for that, but thanks for the question, Katie.
Great, thank you. I think we're on to, I think sort of the last bit before we hit Q&A here.
Yeah, go ahead and cover those. You're better at the tech stuff anyway.
No, well, okay, we're going to ad-lib this, but we just want to make sure that you guys have access to tools that are hopefully going to make this a little bit easier for you. So just a couple of places that you can start. Free and low-cost data visualization tools, Google Public Health data, or, like Sean had mentioned earlier, your state's own dashboards. Simple charts can really make a big impact. I also do want to mention that all of the slide decks that we're using for these webinars, we've created public links. You are welcome to use them. We had somebody reach out and say, hey, I want to go do some community presentations or start talking to people. Is this something I can use? And we said, yes, please do. So don't discount the visuals. Our friends at Bridged Beginnings in Alabama, that's a phenomenal visual that really helps tell the story. So also just want to mention that, we are happy to provide templates and frameworks that you may find helpful. As we sort of get into this webinar, we've promised we're happy to share templates and things for, our organizational structure and, bylaws and things, anything that you can think of that you might need. Let's have the conversation and see if we've already got it created, and we'd be happy to share what we can. So And again, anything that we share, we are happy to make public and put on our website. And I think most importantly, Sean and I were talking about this yesterday. Don't forget to utilize. There's so much wealth of knowledge and data available, through our websites and things for the pediatric transitional care facilities that have already been established. In addition to our friends at Generation O, I think we talked about them back in our first webinar. They are doing a lot of the informational sharing and synthesizing a lot of the research that's come out around opioid exposure. And so, feel free to visit these websites and utilize information that our network of clinics is already sharing. Really think of this as laying the foundation of the nurseries that you all are trying to create. So, really by showing the need with both data and the storytelling, you're really positioning your projects not as just a dream, but that you have a solution to this very real problem that we're seeing in our communities. So with that, I would love to transition us over right in the nick of time over to, oh, thank you. I see Lynette from Generation O is on our webinar today, and she shared the link to their organization's website. You guys will, there's just a ridiculous amount of information there. So please go visit them and reach out if you have questions. But just in the nick of time, we are at 5 o'clock. And so we're going to dive into our Q&A. If you have a question that we haven't already answered, please utilize that Q&A feature. I've answered one or two, I think, in there, but I'm only seeing a couple in here so far. So Sean, Sophie is wondering if you could talk a little bit about what's included in the daily costs here at Maddie's Place. We talked about that, for $800. I think we had a graph up here that showed, what we're able to provide compared to
Right. Yeah.
NICUs.
So basically, I think not the next webinar, but I think the fifth webinar, we're going to really spend the whole time on going over our financial model and our staffing model. But just to give you, a lot of people are surprised at how many employees we have. I think we have 91 staff now. But a lot of our employees are part-time. And so if you look at it on an FTE basis, we're at about 60, something like that. But we are a 24/7, three-shift facility. By our state regulations, we have to have at least one RN on shift at all times. And then we have to have at least one infant care specialist for every 4 infants that we have. And so we're licensed to treat up to 16 infants. So that by regulation, we need to have at least 4 infant care specialists on every single shift, in addition to the one nurse. With the model of care, that structure was designed on a facility that in Kent, Washington, which only treats the infants and is in action. And so since we are also, we're really treating the dyad, and so we have to have additional employees because we've got the moms that are there. This is not a NIC unit where it's just a pristine environment and there aren't any of the social complications that you're bringing into it when you're also dealing with moms and our dads that are themselves on their own journeys going through recovery, and with many of them just in the very, very early stages of their recovery, like the first week. And so we do have, and we have a lot of peer support employees. So that is, our budget's around 4.1 million per year right now. And we are trying to really hone in on, we have, you can't believe this, I just found out today, we have 500 folks that have volunteered to help out here. We have one of the groups are called cuddlers, and so they do 4-hour shifts. They're trained. They have to have all their vaccinations. We have to have their background checks and everything. But we're looking for ways that we can to reduce the cost per day for our infants. We don't have any expensive medical equipment. We're in a facility that is 20 years old that we bought for $1.25 million, 12,000 square feet. So that's $100 a foot. That's not that much. And we've remodeled it for 2 million, 2.5, which is another $200 a foot. So we've got a state-of-the-art facility. So I think we're hoping that we will get Bridget's Path in Dayton, Ohio. Just got their Medicaid rates just went into effect on July 1st, based on a law that the Ohio legislature passed in 2023. They receive $559 per day per infant for up to 30 days. And then they receive another $236 for the dyad for the mom for a period up to 90 days. So that's $795 per diem. And I think that's why and we had in our coordinated care, when we were contracting with them during the first 6 months that we were open, our per diem was running at about $804. So it seems like this 800 to 1,000 somewhere is where we're going to be at. Hopefully that helped answer that question a little bit.
Thank you. A couple of points of clarification. We have 500 people interested in volunteering right now. We've got a pretty active group of about 45 folks, cuddlers specifically, that take fairly regular shifts and that kind of thing. So that's a whole nother discussion that we could have about how to manage the just beautiful outpouring of support that we have fielded from our community. So, and I think there was another question I answered. Larry was wondering on the map, what's the difference between the red and blue dots that I had shared. Just wanted to let everybody know that, blue dots indicated, where we had somebody that had said, yes, please connect me. I'm interested in being part of a cohort. The red dots are those cohorts that we're identifying that have, 5 to 7 people at a minimum, where we're sort of seeing some hot spots. So that's the only difference there. But also, let's see, what was the other thing I wanted to mention? Just that we in our first webinar, we talked about our model of care and how important it is, how critical our mission of the dyad, treating the dyad of parent and baby, keeping them together is. I think in an upcoming webinar, like Sean said, we're sort of still building this plane while we fly it. I think it would be good to dive a little deeper into what does care look like for infants day to day in our nurseries, and then as well as the peer support, wraparound care that we're offering to our families as well. So stay tuned for that. We'll try to dedicate at least one of our upcoming webinars to that. So Sean, another question. This comes from Gabby. Wondering, and this is not a silly question, Gabby, but where do you even begin to have the conversation with MCOs, hospitals, behavioral health specialties, et cetera? They say they love the idea that the folks from Alabama at Bridge Beginnings put together that flyer. Would you recommend putting something like that together and just emailing that out to contacts? Really not sure where to begin there.
I think what they've done in Alabama is really, really good. And I think, that's kind of what we did initially here is we'd have like one flyer or one little thing, and we'd send out emails and stuff. And I think having something like that as a PDF attachment and then just sending it to your contacts and your friends and that may be in this space or in behavioral health or MCOs or anyone that or just to start beating the pavement, so to speak, electronically with emails and introduce yourself. And we're going to start this in Birmingham, Alabama, and this is being done around the country. This is a huge need. We're in a hot spot here in Alabama, and we'd love to meet with you and get your thoughts. I mean, it's just starting to make those contacts, and I think things just start really falling in places. I know that's not really specific, guidance, but I mean, that's just what we did. We just, the one thing that was really helpful for me, and I think for Trisha, when we started this, really, she really had the passion. She was a foster parent. She was a nurse. She had experience over literally 20 years of taking care of these infants. She was passionate about it. She was sick about what she was seeing. And so she really had the knowledge base and the passion. I had the Rolodex. I'm in, Spokane. I know a lot of, it's a small town. And so I've been here forever, and I just had a lot of contacts. I ran for Congress once. I knew kind of people that had given me money that were likely to support something I was involved in again. So I think it was the combination of somebody with the passion, and with a really basic understanding of the problem, from a clinical or medical standpoint, or from even a social standpoint, and then at least one person that's got some good contacts with people that. And so what we did, I really, in the first 6 months, we were in the lockdown in Washington State and pretty much nationally, where we couldn't meet with people between June of 2020 and December of 2020, and I had to raise $1 million on Zoom, with just the two of us. And so basically, I would just, start off by introducing my friends or whoever it was to Trisha. She had a little infant at the time, a little girl by the name of Sawyer, who had a horrific story, and had been, born in a toilet in Spokane at 36 weeks. And while the mom was cleaning up the drugs in her place, the little girl had two brain seizures. And anyway, she was in the NICU unit for 4 months. At the end of that time, I mean, she was almost taken off life support a couple times. The hospital ended up asking if Trisha would take care of the baby, and she was carrying that baby in a Moby wrap during that same time we were on Zoom. And I just say to my friends who had a lot of capacity to give, are you familiar with the drug crisis? And they'd go, yes. Are you familiar with the impact it's having on infants around our community? And they'd say, no, I hadn't really thought about it. And then I'd say, Trisha, tell you the story of Sawyer. And this was just on Zoom. And I can't tell you how many people started to break down during a half-hour presentation. And we raised $1 million on Zoom in 6 months. So, and Spokane is not like a super rich area. It's a pretty blue collarish, and we've got but there are plenty of pockets of wealth in this community. And I practiced law for 46 years, corporate law, and represented a lot of these banks and folks, and in the area. And so the money started to come in, and then people would say, you need to talk to this organization, and then I talked to that organization. They'd say, you need to talk to that organization. That was how I reached Excelsior Wellness, which then said, we'll introduce you to the MCOs, and that introduced us to Stacy West at Coordinated Care, and that ended up with $1.1 million. So it's just, yeah, you don't need to start with a ton. Somebody's got to have the passion, and I think there's a lot of people here that do. And then somebody needs to have connections and the ability to start connecting that passion to people that will start to shake things up.
Great. Sort of as an aside or in addition to that question, also wondering if you would suggest using Maddie's Place data to help support potential outcomes. So I'm obviously
totally. Yeah, totally.
And data from your own area is good.
Yes, absolutely. And we have, you can use, there's the Johns Hopkins Harvard article on, what's the title of it? Excuse me.
Reconceptualizing non-pharmacological approaches to mass.
Right. That's it. That's it. Anyway, that provides some credibility with the model of care. It's basically non-pharmacological approach to the treatment of NAS. And this just came out in late 2021. And so that article and then our study is about 50 pages long. It's on our website. Use it because I think there's so much of it that's applicable to around the country. And I don't know, you probably can't pull that up. I don't know if you can multitask that good, Katie.
I'm sharing in our in the chat. You guys will see I'm dropping articles.
Oh yeah, there it is.
And links
there it
as
is.
you're talking about it. So that link that I just shared, that'll probably take you to it's a scholarly article. There's a paywall. You'll at least be able to see the sort of synopsis of abstract. That's the word I was looking for of it there. But
the full article is on our website under resources, additional reading, and then our Katie, where do we have on our website the our study, the Washington State University study?
I believe that might be under media, but I'll be sure to get that dropped into
it should be under resources.
Under resources,
folks aren't going to find it under media, but you definitely should and can and should use our study.
Great. Let's see. Next question. Oh, this is a good question, Sean. Do you have separate contracts for billing for mother and spouse incurred costs? So I think, are we billing separately for baby versus, the parent that we might be supporting?
Yeah. So right now we're not billing for anything. And that's our challenge is to get our state to amend its state Medicaid plan so that we get a per diem payment from our MCOs that we can then contract with. They all want to contract with us, but unless they're going to get reimbursed by our state Medicaid plan, which is our healthcare authority, then they won't contract with us. So that's really the issue. What we're trying to get is a per diem for the infant that would be paid under our state Medicaid plan through all the MCOs. So if a mom comes in and she's on Molina and the baby's then on Molina, and then Molina will pay us, $585 or whatever the per diem is per day for the treatment of the infant. What we're looking for with the Ohio model is that our Department of Children, Youth, and Families would provide something like $250 a day for the dyadic treatment, for the treatment of the mom that we're providing. So the total between those two would be roughly $800 per day. So anyway, that's right now we don't have a billing department. We don't, we're not. So our budget's 4.1 million. How do we cover our budget? We get paid $2 million this next year by the state of Washington, which is an extension of our pilot. We get paid $750,000 a year by the county of Spokane, which is blown away by what's happened, the 95% statistic with what's happening with our parents. We just got $300,000 from the city of Spokane, and so that's $3,050,000. And then we just got $300,000 from a foundation that's payable over 3 years. Katie and I have to raise $1 million a year, so we're doing that, but we want to, I'm 75, this is not sustainable. So we need to be paid by Medicaid and by our state, probably through our Department of Children, Youth, and Families. So Ohio has come up with a model that I think will work in Washington. I'm spending most of my time meeting with state legislators and agency heads to get them to agree to adopt the Ohio model here in Washington State.
Great. So on that note, how close are you to securing Medicaid payment in Washington? And do you expect the Miracle Act the study that comes from that will help convince states to help cover costs for PTCFs most, or is that geared more towards reaching national level awareness and funding?
Well, our discussions we're waiting with bated breath to find out what the governor's office is going to do with our facility. There's a lot of discussions that are going on, and we're waiting to hear about that. And like any day, any week. The head of DCYF, a woman named Tana Sen, loves what we're doing. Met with her in early June, and she's coming for a visit to Maddie's place on October 8th. And so we're hoping that between the discussions that are happening with our healthcare authority and with the governor's office right now that are ongoing, and also with the meeting that'll be upcoming with Tana Sen, that we'll be able to put together a package with the governor's office. If not, we are meeting with legislators, all the chairs, vice chairs, ranking members of the key committees in health, early learning, appropriations, ways and means in our House and Senate, to have the legislature do this. And then hopefully the governor would approve it. So we'd love to have it come from the governor this session, this next 3 months. His budget is coming out in the next month, I believe, and we're hoping that we'll be included in it. I do think, in the second part of your question, I do think that a national study that shows the severity of the problem will be of enormous benefit to each of you in each of your states in convincing your states to expressly cover NAS services provided by facilities like ours in your state. I think it's going to be critical. And it's going to take a couple of years or whatever to raise the money, locate the facility, get your team together, and all that. So that study will be done before we know it. So hopefully it'll all align when you're ready to open your facilities.
Wonderful. I'm not seeing any other questions hanging out. So if you have them, please feel free to drop them into the chat. Now we do have a couple of more minutes. And
one thing, while we're just filling just a little bit of time, Katie and I are doing our best to kind of respond to kind of what we're seeing, and then going webinar by webinar. If we could cover the clinical care and have our clinical people, our nursing staff, be one of the next ones we do, or we could do the financial model and cover that, or we could cover what was the one we actually have on for next time? I'm kind of upsetting one of the slides that you have for the next webinar.
That's next. So talking about Medicaid implications, how that's impacting things, licensing, and legislative advocacy. So we had planned to dive into that. So on that note, I'm just gonna give me just a second. I'm gonna switch gears here, or at least switch to the next slide, so you can see what we have coming up next. So this will be our topic for our next webinar coming up on October 16th. That registration link is actually live on our website right now. And then we will follow up with a reminder. Hopefully you guys aren't feeling spammed or overwhelmed. We're trying to find a really good balance of sharing information with those of you who have signed up and said, yes, we want to be part of this process or learn more. So if there comes a time where you say, nope, we just don't want to be involved anymore, please remove me from those communications. Please just let us know. Just trying to make sure that you all have all of the tools that you need, all of the information you need to stay connected and move forward in your efforts. So, our next legislative session, Working with the System, Medicaid Licensing and Legislative Advocacy, will be held on Tuesday, October 16th. We'll be covering, or at least touching base, talking about licensing. What type of facility do you want to be? Are you going to be residential, behavioral health, medical of some kind? We are really, really hopeful. We are planning to extend invitations to a couple of really key folks that we hope will be available to join us to talk about some of the people and organizations that we collaborated with as we got started. Sean talked about, I think, all of them today, specifically, community healthcare organization, that was Excelsior Wellness, one of our MCOs, that was Coordinated Care, and then some of our state agencies. And we're hopeful that our lobbyist, John Colton, will be able to join us as well. Also to touch base on, legislative timeline and talking points and that kind of thing, dive a little deeper into those areas. and how to build relationships with policymakers and agency staff. Really get you in front of the people that are going to be key decision makers that will help move your efforts forward. So I am not seeing any additional questions. So with that, I think we will go ahead and wrap up. But like I mentioned, just hope you all will stay connected with us. Any materials that we have shared or make public, recording of this will be available on our website, and hope you'll be sure to register for those upcoming webinars. You can also reach us directly. The info is there on your screen at info@maddiesplace.org, or you can visit our website, maddiesplace.org, and just click on that resource tab and select Want a Maddie's Place in your community for more information. So just want you all to know that your interest and your participation in these webinars is really helping build a national movement of hope and healing, and we're just really grateful for all of you being on this journey with us. So we hope to see you all next month, October 16th, for our next webinar.
Yeah, and I just want to add on to what Katie said. I mean, it's just been so wonderful to see kind of the outpouring, and that this many talented people around the country are really interested in doing what we're doing or something similar to it. And so it's an encouragement to us, and hopefully we're an encouragement to you. And yeah, we're excited to see what comes from this. So let us know, if you have ideas for how you want the next webinars to go, or different things that you want us to cover. We're kind of building this clinic. As I tell everyone, we're building the airplane as we fly it, and we're sort of building the webinar airplane as we fly it too. So we want to be responsive to what you want to hear, and not go on and on about a subject that you're not particularly interested in right now. So anyway, let us know if the things you want to hear. We've kind of got it mapped out as Katie's outlined. And if we don't hear to the contrary, well, we will cover advocacy. We have John Colton lined up for the next one, and we've got a couple other people we'll be reaching out to. So you won't have to just listen to me, which will be a huge blessing. And we'll get more people involved on the clinical side too, when we get it cover the model of care in a little bit more depth for those of you that really have the clinical expertise and really want to know, okay, what are the nuances of this non-pharmacological model? So anyway, with that, thank you so much. We really appreciate you. You're a huge encouragement, and I just wish you the best tonight. Thank you so much.
Bye, everyone.
Bye.